as I said. Whoops, hang on, let me just go back a moment. Right, so to everyone on the call, first of all, welcome. This is the monthly clinical webinar. We're recording the session, as you all have heard earlier, and I'll make the recording available after the webinar. So a bit of kind of housekeeping first. So the two presenters this evening are Monica Jones, who's the Chief Data Officer at HDRUK and works at the Hub for Cancer, so DataCan. And she's going to be talking about COVID and cancer and the use of real-time data and open standards. And then my two colleagues from Sweden, so Daniel Karlsson and Keng-Ling Wallin. They're from, I can never say this, Socialstyrelsen, which is the National Board for Health and Welfare in Sweden. And they're going to be talking about clinical engagement in Sweden and some of the work that they're doing. But just before we start, a bit of advertising. We're starting an implementation web series which is new. That'll be coming up shortly on the 3rd, so tomorrow, in fact. We'll be talking about natural language processing and SNOMED CT and the migration of clinical data using NLP and SNOMED in Belgium. And the experiences of natural language processing in Malaysia in MyHarmony. In addition, we've got a research web series coming up on the 16th, and details of that and for more information, if you go onto our website, snomed.org, you'll see under web series, all the details will appear on there, how to log in and register for each event. A bit of advertising. We have our expo coming up shortly on the 8th and 9th of October. It's the first time we've ever run something virtually. So there'll be 49 sessions over 2 days. We've got 20 posters so far and over 750 registered and delegates from over 50 countries globally. So it should be a very good event, and I definitely recommend you all look at details and come and join us. When I started, I said we run clinical webinars every month. The October one is slightly different. Before the expo, so on the day before, on Wednesday the 7th of October, we're going to be looking at hosting a clinical day. I use the word very loosely. We're going to run a session for about 4.5 hours, but we'll have breaks in between, so you don't need to sit in front of your computer for 4.5 hours. We're going to run a 2-hour session at the start, looking at an overview and a bit of discussion about clinical developments and clinical engagement in general, and some of the work that's going on within member countries and also from SNOMED International. Then there'll be an 1.5 hours when individual clinical reference groups will be meeting. All of the clinical reference groups are open, so you can join any of them, whether you're a member of the group or not. And then after that, we'll pull everybody back in for about half an hour and do a bit of a closing plenary session and do a bit of a summary of all the meetings. The timings are all in UTC, so we've tried to arrange it as best we can, bearing in mind we have a global audience. But I definitely recommend that you look and see if you're available to join. If you can't join, all those sessions will be recorded and we'll make the recordings available afterwards. So even if you can't attend, you can at least see what's going on. And with that, I'm going to stop sharing. I'm going to hand over to Monica. So Monica, as they say on the stage, take it away.
Take it away. Okie dokie. How long have I got here?
So we usually work on about 35-40 minutes for each presentation, and then we'll do questions at the end. I should say to the audience, if you want to ask questions as we go along, please put them in the chat window or the QA window, and I'll moderate and look at making sure we get answers to your questions. So, Monica, over to you.
Right. Well, I hope that, can you see my screen? Okay.
Yep.
Yes, we can see your screen.
Okay, great. Well, thanks very much, Ian, for that introduction, and it's lovely to be invited to speak to the group tonight. As Ian said, I'm Monica Jones. I have a number of hats, mainly because I'm a girl who can't say no, but perhaps I've just been around long enough.
No, I found a new link, so I'm on.
Oh, is that Charles? Are you okay? Right.
Yeah, I'm fine, thanks, sorry.
So yeah, my main job is as Chief Data Officer for the HDRUK Hub for Cancer Data Can. I'm also Associate Director for the HDRUK North, so each of region across the UK has a sort of a centre, and there are core sort of programs and aims. We're focusing on better care partnership, and particularly around sort of frailty in the north. And I also sort of, with my NHS hat on, I'm the exec lead for the Yorkshire Humber Care Record for population health management. So what I thought I'd do today is just try and combine all of those things and tell you about some of the most recent work we've been doing, particularly around COVID. So the next sort of half hour, I'm going to just give you a little bit of background to HDRUK hubs and DataCan, closely followed by my take on what the need is for linked longitudinal records, shared care records, and the LHCRE program, but in particular sort of what we've been doing in Yorkshire and Humber. And then sort of moving on to sort of COVID and the impact on NHS cancer services and outcomes. And probably 3 and 4 sort of merged together in terms of the use of real-time data, clinical terminologies. I'll talk a little bit about my sort of past in terms of implementing SNOMED CT in the NHS in the front line at an integrated trust, and why it's so important to have open standards in order to be able to do all these things that we have to do. A quick canter through what the plans are for the future, and then hopefully enough time for questions and answers. So hopefully that's what people were expecting to dial into. So I find this slide useful because it really sort of encapsulates what HDRUK is about. So HDRUK is recently formed the last sort of couple of years or so. And it's funded actually through the Industry Strategy Fund, directly from central government. And it's about improving health data in response essentially to a lot of sort of feedback that we get around that we've got this richness of NHS data, and we've got, a fantastic NHS here in the UK, but actually it is still very difficult to get legitimate access to those data. And it's really about bringing people together on a set of sort of principles, but also with funding in order to be able to unite that healthcare data. So the last year on the 1st of October, there were 7 hubs that were created. So that's the bit in the middle. Some of them specialty related and some of them cross-cutting sort of themes, with the aim of being that sort of honest broker between the UK Health Data Research Alliance, which are essentially a number of NHS and broader public sector organisations who've committed to providing data for research, and then those are surfaced through the Health Data Research Innovation Gateway, which is essentially the shop window in order to be able to see sort of what is available and what people are prepared to share. The most important thing is around this is, of course, the patient and the public benefit, and making sure that we're providing fair value, but also that anything that we do has is trustworthy, and that it has the full agreement of patients and public. And certainly at DataCan, we've got very heavy involvement from patient and public. So these are the sort of things that that actually are delivered as part of the of HDRUK. You can see the hubs along the bottom. So we've all got snazzy little names, you know, that sort of describe what we're doing. So the data can, not unsurprisingly, is around cancer. Breathe is about respiratory disease. Gut reaction is about inflammatory bowel disease and extended GI. The insight is around eye care. And then you've got the Discover Now, which is the real world evidence one, and the Pioneer, which is about frontline acute data with the British Heart Foundation Data Science Centre that isn't funded by HDRUK, it's directly from BHF, and then the Human Phenome and Applied Analytics through Genomics England and other sites. So I really just wanted to give sort of a little bit of a background. We've been moving at pace. The initial sort of hubs are funded for 3 years until 2022, but the expectation is that they become self-sustaining, and actually through the industry connections that actually we can sort of grow and develop. So I've tried here to put our vision of DataCan sort of on a page, and that's very much around that sort of linked longitudinal sort of records research. So, you know, we need linked longitudinal records for direct care and for secondary uses, but also for research. And that's about getting, you know, high quality curated data, both structured and potentially through plain text as well, but also other sort of formats like radiology, pathology, genetic and molecular data, particularly in cancer research, which is, you know, highly specialized, and there are, you know, a whole set of data formats that actually you need to be able to describe in a structured way, and you need to have that interoperability between the systems with the intention of improving access, improving quality, and once again ensuring that that fair value is. So there's a, you know, that having worked in the NHS for a number of years and turned the handle and produced central returns that you know, whether they go to NHS Digital or whether they go elsewhere, you know, sometimes you feel that it's going into a bit of a black hole and you never quite get anything back. And I think that you know, now is the time to actually make sure that the NHS is actually getting that fair value as well, and so it's a two-way thing. So I just briefly wanted to talk about the LHCRE program. So that's over the last sort of 3 years, really. There was an NHS-funded program for in England for the creation of local healthcare record exemplars. That's what LHCRE stands for. It doesn't mean that I'm wearing cycling shorts and looking particularly unattractive. So one of the ones, there are 5 in England that were set up. There's Yorkshire Humber, there is the Greater Manchester, 1 London, Thames Valley and Sussex, and the ancient fiefdom of Wessex. So particularly in Yorkshire Humber, these are some of the health challenges in our region, which are not dissimilar to others, but it's particularly, you know, acute in Yorkshire and Humber, particularly around some of the sort of life expectancy and comorbidities associated with sort of poor health. And you're talking a pretty large region, you know, 5.8 million citizens is larger than Scotland in terms of population, and it brings together 3 ICSs. On that slide it actually says 2 integrated care systems and 1 sustainability and transformation partnership. But Humber Coast and Vale is now an ICS as well. So we're talking West Yorkshire and Harrogate, South Yorkshire and Bassetlaw, and Humber Coast and Vale. So why am I talking about this? So what we need, our aim was to create the Yorkshire Humber Care Record, and rather than actually building something new, this was about building on the good things that we were doing already. but actually then joining that up so that we could have more time to spend with people in care, for particularly for clinicians, improved connectivity and integration, better decision making, reduction in tests. Very grandiose sort of statements there, but actually we've done it in a pretty simple kind of way. So we've created what we call our system of systems. So that is a non-persistent layer of data using HL7 FHIR resources in order to be able to create a longitudinal record on the fly. So by connecting up existing healthcare systems, whether that's directly into the vendor system or whether that's through an existing shared care record, we've been able to connect up people who are on particular pathways, so we can look at the whole sort of pathway. And as a LHCRE, Yorkshire Humber were the first to get over the line, so we had to deliver everything in order to get our £7.5 million from NHS England by March this year. But that wasn't the end, that was essentially just the beginning. So what we've basically are doing over the next 5 to 7 years is continuing to invest in that. Each of the 3 ICSs has committed to additional funding in order to connect up our system of systems. So at the moment we've got a number of sites. So we've got Leeds, which already had the Leeds Care Record, Rotherham, which had the Rotherham Health Record, which is where I worked most recently at Rotherham Foundation Trust, Doncaster, Hull, and Yorkshire Ambulance Service. We're extending that now into the other areas across Yorkshire and Humber, so Bradford, Barnsley, Hull, York, Sheffield, and with the intention of ultimately joining all of those things up. So once we've created our longitudinal record for direct care, so somebody who's perhaps got, thinks that they may have cancer and they're in Rotherham, they go to their GP, they'll get a referral to the hospital, they'll go and see an oncologist who will probably send them for some test scans and what have you, probably in Sheffield. But if it's they need sort of a second opinion or particularly sort of rare cancer or there's particular sort of pathway, then they may get a referral to Leeds. Now, classically, those bits haven't been joined up, but what we've done with those particular sort of pathways is that the oncologist in Leeds can actually log on to his or her instance of the Leeds Care Record, and they can actually see the elements from Rotherham, Sheffield, and the GP can actually see all the bits joined up as well, and it's surfaced through their own portal. And that's the power of open standards and interoperability. The advantage also of joining these data up for direct care is that we can then use it for population health management. So this diagram here shows what I refer to as Monica's Wheel of Fortune, which is one of the models around sort of population health management. And when you get the slides, you can click on the link there, and there's an animated version of this that has some embedded video that will take you through a broader explanation. But it's really about defining what your population is, so using tools like population segmentation in order to be able to identify those care gaps, where you've got particular sort of cohorts who may have very high levels of deprivation and poor outcomes, and high levels of comorbidity, and areas where you can really sort of focus in on managing that care. That then leads us to risk stratification, which classically we've done in primary care in the UK by particularly focusing around avoiding hospital admissions. But frankly, with the quality of the data now that we can generate, we can do much more predictive analysis, and we can actually do much more real-time analysis. And then it's important to engage with that patient, which is generally best done by a clinician. Normally sort of within primary care, having those conversations that can be in the community and can also be through secondary care as well. And then the management of care and measuring the outcomes and going back around the loop. So with the funding that we had, we actually went out to contract through the HSSF framework, and we formed a collaboration with Deloitte, Google and Synonetics, who actually brought their resources together for a 5-year contract in order to build this population health management solution. So it's a Google Cloud platform. The system of systems is on the left-hand side. And the data comes through in FHIR resources, but also wherever possible, we want that to be structured. We want it to be, you know, fully defined in using clinical terminologies, particularly SNOMED CT, because what you can do then in terms of the analytics service is so much more powerful, as I'm sure many people on the call will know. It then comes through the integration services and into Google BigQuery, and then we've got analytics visualization as part of that. And you can see from this diagram what the component parts are of that. And then we have a number of use cases. We started with living with and beyond cancer. We focused on cancer and urgent care, mainly because those are the two areas that we had the poorest outcomes, clinical outcomes across the region. And then this is essentially targeted at two populations in terms of use. The consumers are those who are essentially the commissioners, the health providers, clinicians and health and social care workers. And the developers are the data engineers, the analysts, the scientists. And we've run an academy where we've trained 40 people over the last sort of year, and we'll be running that another 4 times in order to be able to do really some of the in-depth and fantastic analytics that are available by having these integrated services. And these are some of this is just an example of a dashboard, but you know, sort of taking the data, slicing and dicing it by primary care network, looking at emergency admissions with cancer, and looking at ethnicity, age, and other component parts of it. So there are many more things that we're doing with it. We've lifted and shifted some large data sets. So in Leeds, there's a comprehensive patient record that was a Macmillan-funded program of approximately some 430,000 patients over a 10-year period, linked primary and secondary care data. So anybody who is referred into Leeds Teaching Hospital Trust on a 2-week wait. Now, not all of those will subsequently have cancer diagnosis and require treatment. The hit rate normally is about 10%, but actually what it gives us is a fantastic control group in terms of being able to do really rich, deep sort of analysis. So, you know, cancer data has been sort of collected by cancer registries for 70 odd years, but actually that's only about 10, 20% of what actually happens within the system. So by actually going to the source systems and being able to get that structured data and using the open standards is really important. So that then takes me down. So we've looked at things at a national level, we've looked at things at a regional level, and then I just want to sort of pick out a few bits from the local level. So my last role on the front line of the NHS, CIO at Rotherham Foundation Trust, and these are some of the health informatics sort of stats that you get in a standard DGH, such as that. But actually, you very quickly get a lot of data. You know, 750 terabytes of data storage just for one trust. You know, 500,000 lines of bespoke code developed for the Rotherham Health Record, and 2 billion data items and 50 million messages. You need to manage that well, and you actually need to have that in a very well-defined kind of way. So we implemented SNOMED across the trust. It's been used for a number of years, and we also made sure that we had it, you know, more detailed terms that wanted to get the benefit rather than just using ICD-10 and OPCS. That doesn't mean that it isn't then mapped and turned into that for remuneration purposes, but actually all of the point of care data is captured within the system and recorded using SNOMED CT. All the way along, it was really important to have that clinical ownership, and I'm absolutely certain that the reason we were able to have create the Rotherham Health Record was because we had this clinical ownership, and we actually had that sort of real sort of buy-in. Because once you've actually got that captured in a structured way, and that you can play that back and you can get that real-time information, then actually the world is your oyster. So being an integrated trust, by default, you have acute and community data together. You then extend that by adding in 30 GP practices, get all primary care data through MIG for that, and then actually link in the adult social care and the children's social care from district council. And then finally mental health services, which is a shared service through Rotherham, Doncaster and South Humber, R-. And that is a truly rich, integrated sort of record as an exemplar that then allows you to go up to the Yorkshire Care Record, that then allows you to be able to go sort of up nationally. And you've got to build it from a bottom up, and really the only way to do that is using clinical terminologies. We found that we had improved data entry and clinical recording. There are a couple of use cases that are actually on both the SNOMED international SNOMED in Action site and on an NHS Digital that actually explains a lot of this. And most importantly, there are those benefits for the patient. That the improved visualization of activity allowed us to cut our waiting lists, record drops of missed appointments, and structured discharge summaries. There are a number of challenges and lessons learned as part of this. You do need to have the specialism. You do need to be able to understand and work with the clinicians. The way that it was deployed using Meditech is actually using heavy users of subsets, but also having the option of clinicians having their favorites, so that actually those terms that are used the most can be put into almost a bespoke subset, and actually the uptake and the ownership of that from a clinical perspective was really well received. That doesn't mean that they can't use the whole of SNOMED, and you can basically go up the hierarchy pretty damn quickly if it's not there. But actually just the response rates and the implementation and understanding how that works was really important. So I've talked very much around the shared care record side of things. What I just want to do for the next sort of 5 to 10 minutes is really talk about the here and now, and that's particularly sort of COVID-19 and cancer. So we started to see in DataCan that there was very much this sort of, patients were starting to fear COVID diagnosis more than a cancer diagnosis. We're anecdotally finding this, and we wanted to look at 3 things in particular: the impact of cancer on COVID-19 infection, the impact of COVID-19 infection on cancer, and then the impact of COVID-19 pandemic on cancer services. So very rapidly, we sort of mobilized our resources, and working with the HDRUK Centre in London, we looked at the impact of comorbidity on cancer, on COVID, on cancer deaths, in terms of the direct effect. So we wanted to do the historical modelling, and everybody was doing historical modelling at the time. But actually, most importantly, we actually wanted to do some prospective sort of modelling and look at the real-time data. So for the background, we looked at the Calibre data set, which comes from the CPRD, 3.86 million records over a 10-year period, and examined the incidence and prevalence of 24 common cancers. We looked at the 15 comorbid conditions defined by PHE as high risks, and then what the 1-year mortality for each site and the number of comorbidities. And you can see that actually colorectal and breast and lung there, came out as some of the highest, and the comorbidities associated with the worst outcomes were, cardiovascular disease, hypertension, diabetes, COPD, chronic kidney disease, all the things that actually, you know, have massively affected the survival rates of people with cancer. And the modelling that we did along the bottom is sort of from best to worst in terms of what we were trying to predict would be, you know, the excess deaths associated with this. But in order to substantiate it, we started to look at real-time data. So what we did was, through our own sort of network, we reached out, particularly in Leeds, in London, and in Northern Ireland, because the partners of DataCan are UCL partners in London, University of Leeds, Leeds Teaching Hospital, Queen's University Belfast, Genomics England, and IQVIA as our industry partner. And what we could see, and you can see from these diagrams, we looked at two particular sort of component parts. One was about urgent referral for early diagnosis, so 2-week wait referrals, and chemotherapy. And you can see then, sort of in about February time, consistently, this massive drop off in terms of the referrals and also the attendances for chemotherapy. And you normally see that sort of dip at Christmas time, a little bit sort of at Easter sometimes, but it looked like we were going into a perpetual Narnia winter at this point. And the modelling came out that the direct and indirect effect combined there was an estimate of between 6,000 to 17,000 excess deaths, and there was a lot of publicity. We were published. We were on the front page of the Guardian, room. The Panorama programme referred to our work. But actually, one of the things was it was a call to action. So it was a call to action to the government that actually their message had been, in a way, there was one message and one response. And here you can see Boris sort of, you know, stay home, protect the NHS, save lives. And there was one response: they stayed home and they didn't go to hospital. So there was no referrals for, you know, there was a 70-odd% drop in referrals for early diagnosis, and there was 80% sort of drop in attendances for chemo. Now, some of that was actually, you know, they did that to protect the NHS, and so they did save lives. But the consequence in terms of cancer diagnosis was substantial. And so really you can see this is looking at Leeds data in particular, about the sort of the local problem, and you have to look at the national consistency and the regional differences in terms of the way it's sort of handled. But in terms of the, you know, the peak and the drop in terms of COVID admission to Leeds Teaching Hospital, then essentially you can see sort of what the differences are. Why did we want sort of to use real-time data? Because if you wait for the data for it to come through the national systems, then frankly you're waiting for sort of 2 to 3 months, even with the 2-week referrals. The data that we can get, this was data obtained by the 9th of June. I've got later data, and you can see that there is a recovery coming up. But we're at that stage, there are about 3,200 missing referrals in Leeds, and Leeds accounts for about 1% of the English cancer activity. So you don't need to be, you know, sort of good at maths really in order to work out what, you know, what the extent of those missing referrals are. And so really it was a call to action to both NHS England and to the government to say, look, we've got to, you know, get cancer services back on track. And the latest directive that came from Simon Stevens on the 31st of July, you know, about the phase 3 sort of recovery, put absolutely at the top of the list that cancer services need to get back on track. There will be people who are lost in there, and you know, that shouldn't have happened, but we've just got to make sure that it doesn't happen again, and that actually we can manage our services. So what we want to do moving on from this is actually formalize this, this real-time data network. So with our existing partners, we're going to be bringing the data into the Yorkshire Humber Care Record, into the HDRUK, which is all GDPR compliant. It acts as a trusted research environment. It uses the national de-identification tool Privitar for pseudonymization, and it is fully compliant with the national opt-out. And so we can get that flow coming through, and then we're going to extend that out to the major cancer centres across the UK. We're a UK organisation, so we want to be able to do this using a common, simple data model, using structured data, and using wherever possible the clinical terminologies. So that's all I had to say, and so I will open it up to questions. Thank you very much for listening.
So thank you, Monica. So we've got time for we've got some quick questions. So I had one question for you. Well, actually, I had one. One of my colleagues had one question for you. So we've been doing some developments around data analysis and looking at subsumption testing as part of that. In terms of the way you do analysis, do you do anything like that? Do you use subsumption? Do you use SNOMED hierarchies? Or are you doing it the more traditional way, I'll call it?
If I'm being brutally honest, then it is more traditional, but the expectation is that that we'll use, you know, deeper analysis, and particularly once we actually have formalized our real-time network and we've got that coming into the HDRUK, then actually we would intend to use subsumption and get that contextual information, the additional sort of, you know, strength that comes from the from using terminology such as SNOMED. So yeah, at the moment it is more traditional, and some of the modelling. I noticed there was a question on the chat around OMOD.
Yeah.
Yeah. So on the we have been using OMOD, not specifically for this data. So the COVID project, which is another project which is being led by the Pioneer Hub out of Birmingham. So that's the acute care one, in partnership with UCLH and LTHD, is mapping, is using OMOP schema. But what we've done is we have reverse engineered that into FHIR resources so that we can get a live feed, certainly from LTHT, into the HDRUK. And once again, we want to be able to, you know, to capitalize on the power of SNOMED, where we've got that described in the data. We've got the live feed from Rotherham, so our intention is to extend across Yorkshire Humber as well, and actually be able to do much more in-depth sort of modelling around that. But you know, it's still relatively early days. But if anybody wants to offer their resources or chat about it more, then that would be great, because we're sort of doing the definition of this, so that would be good.
Okay, thank you. So I'm going to stop the questions there, but we'll have some time for questions at the end. But I'm going to hand over to Daniel and Keng-Ling now. So Daniel, if you want to share your screen.
Yes, please.
So bottom of the screen. There you go.
Yep.
So we're now looking at the SNOMED browser.
Yeah,
in Swedish.
in Swedish. That was
it's good.
my intention. Yeah. So I hope you'll realize the challenge that lies in being the speaker after Monica Jones. Really excellent and exciting presentation. So this is going to be a slightly different presentation. It's so I'm Daniel Karlsson. I'm a government bureaucrat working at the National Board of Health. And I have my excellent colleague Keng-Ling. I'll let you introduce yourself. And
yes,
Ling?
I'm
Yeah.
on mute.
Oh,
yes,
yeah. Okay. Yeah.
that's
Great.
right.
So,
Okay. Thank you, Daniel. My name is Keng-Ling, and I'm working together with Daniel in the same division for information structure and e-health at the National Board of Health and Welfare in Sweden. Yes, we are very honored. Ian, thank you very much for giving us the opportunity to talk a little bit about how we work with clinicians in SNOMED city in Sweden. Would you like to take over now, Daniel?
sure. So let's see why. Yeah, there. So today we're going to talk a bit about healthcare and healthcare knowledge management in Sweden, so that you understand some of the reasons why we work the way we work at the NRC with clinical engagement, and then we'll talk a bit more about what we do and give some examples and also try to describe some challenges that we've seen in the work and what we're trying to achieve. So healthcare in Sweden. So Sweden has it's divided in 290 municipalities. That's what you see in gray. Let's see if I could get my on the right hand part of the screen. It is also at the same time divided into 21 regional councils, and as you might know already, Swedish healthcare is largely government funded and heavily decentralized. So healthcare is mainly a responsibility of the 21 regional councils, and they are all self-governed. They have taxation rights, so they have their own budget. The national central government can set like the agenda and make law and ordinances that can to some extent control how healthcare is delivered, but it's a kind of a blunt instrument, and particularly since there is at least limited financial power of the national government, since the main funding for healthcare is through regional taxes or municipality taxes. So that this is how Sweden works, and that's what we have to work with. And so if you take this a step further and look how healthcare knowledge management is managed in Sweden, and I'm so knowledge in this domain is of course created very much and shared on the international level, but we won't talk that much about the international level today. So at the national level, there are a number of government agencies related to healthcare. So it's our government agency, the Board of Health and Welfare, is one of those. There is a public health agency responsible for among other things, the Swedish COVID strategy, which is fairly famous by now. We have a medical progress agency. We have actually an e-health agency which has some responsibility for e-health, but not complete, mainly to do with medication e-health. I see things flashing in the chat. Is there anything that I should?
No, it's okay.
Okay, yep,
I'll
okay,
keep an eye
fine.
on that.
Great. So also on the national level, there are professional societies for both different healthcare professions have their professional societies, which have a large role in knowledge management for healthcare in Sweden, as in other countries. On the next level down, and this is the regional and also sometimes multi-regional level, there are various structures that have been implemented in order to assure consistent knowledge management and dissemination of knowledge in healthcare. So the regions are collaborating in a national organization for regions, and they've set up a number of national program areas. We'll talk more about that, which are to be responsible for certain knowledge areas. This is an organization that is being set up now, so they are not yet fully functional. There are national collaboration groups. So apart from this 21 county councils, they also in some areas collaborate in actually they're also called healthcare regions, but this is the colored parts we see in the mid map here. So there is a southern healthcare region, an eastern and a western, and a northern and so on. And in some areas, so for example, for cancer care, there are collaboration in these larger regions, and typically there is at least one university hospital in each of these regions for where specialized care or subspecialized care is concentrated. And then there are collaborations of various kinds through the regions which share the same EHR system vendor, for example, collaborate on some issues and so on. So this is also a quite fragmented situation, both when it comes to healthcare delivery and healthcare knowledge management. And also this is what we have to work with as a national release center supporting this knowledge infrastructure. So I'll let Keng-Ling explain a bit about the NRC.
Right. Yes. We are the National Board of Health and Welfare, one of the health agencies under the Swedish government. And our particular unit, as I mentioned, we belong to the unit of information structure in e-health, and we are the NRC for SNOMED City. So many people would think that the whole board was the NRC, but actually it's our unit that's responsible for the maintenance of SNOMED City terminology, and specifically the Swedish extensions. So ever since Sweden joined SNOMED International, I think that was way back in 2005, 2006, and work started plans for implementation or adoption of SNOMED CT into Sweden, there was a decision then made to translate the SNOMED CT into Swedish. And this work is ongoing. And at the NRC, we have 2 releases a year, one in May and the other one is in November. So we try very hard to meet these 2 deadlines, and in between we provide educational, advisory, and terminology-based support services to all SNOMED CT users that Daniel just mentioned about, regional-wise, as well as up to professional, what I call the medical profession levels. And sometimes even we communicate also with the vendors. So these activities are mainly primary for implementation purposes. So we can take the next slide, Daniel. Or
yes. So clinical engagement from the NSC perspective is it's not like a single activity that we do, and for most of the part that's not something that we do that we are doing ourselves, but something that we are collaborating with others to ensure. Now I will talk a bit more about that, but if we start at the NRC, we are a mix of staff with clinical and non-clinical or informatics background. So we employ at the NRC, we employ doctors, nurses, pharmacists, biologists, etc. So we assure that there is at least some understanding of the domain at the NRC. So I would say that the most part of the staff at the NRC have a clinical background. So we also work with getting clinical engagement in projects where we collaborate with others, and like that could be either projects or it could be maintenance of knowledge artifacts, templates, implementation systems, whatever it is. There are typically clinical reference groups available in those projects, and there we work with those groups to ensure that we get the level of engagement that we need to do a good job. We work with professional societies, so we have a number of them who are involved in the translation, so we could try to get as high quality translations as possible by using the language that is used in healthcare practice, and for that purpose we work with professionals, a few professional societies, but we also have development projects together with professional societies. We also work with healthcare region, and particularly, and we'll talk more about that, there's been a large investment in new healthcare system in recent years. So from 2018 until today, I think about 2/3 of the citizens of Sweden has gained a new healthcare information system, or there's been a procurement of a new healthcare information system, even though not all of them have been put in real practice yet, but that work is ongoing. So that is a lot of activity in the regions, and the regions themselves, they have large armies of clinicians, which we try to engage with to work with SNOMED and to support. So a typical process from our side in working with clinical projects. I think it's first important to note that SNOMED CD is a means to an end, and that problem or issue that is addressed by use of SNOMED, we as an NRC, we are never the owners of that problem as an NRC. There are related activities at the Board of Health and on the government level where we have some responsibility, but typically we have a set of stakeholders or a stakeholder, and either we have identified the stakeholder or the stakeholder has identified us. There's a shift now that now it's probably more common that we are being contacted than we are contacting those stakeholders. We try to specify requirements, identify the resources needed in both project and even more importantly in the maintenance phase. We try to provide education. So we have done quite a few times so that we provide an initial orientation. Maybe we have a day of where we go to that could be a healthcare region or some other group, and we provide an introduction to SNOMED in Swedish and with a Swedish perspective. But typically we also point those who are going to work with the terminology to the SNOMED international courses, and I think now that we're in a position where we have, I think, like 20 authoring level 1 graduates who are working with SNOMED CT in different ways among these different stakeholders. We also do support of the SNOMED CT work, so we give guidance. We have until recently we've been the only ones from the NRC to do actual SNOMED authoring. We are trying now to we have one of the healthcare regions that we saw on the map before have put a large number of their staff through the authoring level 1 course, and they're now being working in the SNOMED authoring tool to address some issues that they find in SNOMED with, for example, the translation, but also to create new content for their specific needs. And we also have, whenever something is put into SNOMED CT, if there is a new concept, there is a responsibility for maintaining that content. So there is a transition to maintenance that is part of this process. We, as I said before, this is a map of Sweden. We have social care, which is largely responsibility of the municipalities, and there I think this is true not only in Sweden, that the digitalization is not as it's not going at the same pace as the digitalization in healthcare, or it's starting to accelerate, and we've had so far only one municipality, the municipality of Stockholm, the capital and largest city in Sweden, to contact us and to discuss the use of SNOMED in this domain. When it comes to healthcare, about 2/3 of Swedish citizens, that is that we have 2 Cerner Millennium systems being set up in 2 parts of Sweden. We have a Swedish vendor, Cambio, which has been successful and have a large part. That's all that is white and yellow on the map is the Cambio vendor system, and Stockholm, which is and Gotland, which is island to the east, is yet undecided, but will make a decision in the coming year or so. All of the procurements have had SNOMED CT as a requirement. So and all of these regions are I would say varying, but still to some degree working with SNOMED. What is specific about and interesting from a clinical engagement perspective is that these regions have really armies of clinicians working to get the systems configured. So they have several times more staff employed to work with health information structures than we do. So what we want to do is, as much as possible, is to team up with the work that is happening in these regions right now, and we've been, I think, somewhat successful with at least some of the regions. So we're working with clinical engagement in a large number of projects, and we will mention just a few. So we one particular project is that there's going to be a national medication list in Sweden. So there's one list for all healthcare, for like one list for each patient, of course, and that was a strong political pressure. So there was actually a law which was supposed to be enacted this June, but due to COVID, it was postponed. But it's going to be enacted, and so this is an example where there is a national pressure from the top down to implement this national medication list. But even in this project, there is a collaboration between various government agencies with the pharmacological competencies needed to be able to represent information about drugs and prescriptions in the national medication list, as well as clinical competencies to determine what information is needed from a clinical perspective. So there has been in this project we have worked with clinicians in the healthcare regions to determine SNOMED subsets for use in the national medication lists. So with this example, I will leave the for Keng-Ling to continue with more examples.
Yeah, thank you very much,
Sorry.
Daniel. Yes, another important project that is ongoing in Sweden is in the area of anatomical pathology. And in this particular area, we have both national interests as well as international collaborations, like as everybody know, with Scott Campbell in Nebraska. This is in this particular area, instead of the government giving the pressure for us to work on this area, the initiative actually comes from the Swedish Society of Pathologists themselves. The current way of reporting a disease today is using HDRUK, but then we discovered that every pathology lab in Sweden has a variant of their own HDRUK, or we call SNOMED 2, and that raises an issue, a question of how are these data being collected and in quality registries, and how much work is done in controlling the quality of the reports and also the interpretation of what was being reported. And a lot of work in pathology today is still in narrative form, and even though if they are structured, they are in PDF forms. So the Society of Pathologists decided that they want to try something new, and they are moving towards synoptic reports and SNOMED coding every item to SNOMED CT. So the idea, the ambition is that that they would form a repository of synoptic reports, and all of them would be SNOMED coding, and hopefully that the local LIM systems will adopt these synoptic reports for use clinically. So that is one of the projects that we are actively at the NRC, actively in supporting the pathologists. So we have covered a number of areas. We have covered prostate cancer, pancreatic cancer, liver cancer. We are going into lung cancer soon. So that would be a very exciting area to see how the development later is being implemented, and then later reuse, and where the data can be transferred further on to quality registers. So if you would change to the next slide, Daniel.
Sure.
Yeah. So yeah, basically this is again repeating the same thing. We have this work projects where it is the society that we are working directly with. I've mentioned about the pathology project, and Daniel has also earlier on mentioned about the collaboration with the ICMP and the Society of Dietitians. So, and the next slide, please, Daniel. Yeah, there are a number of areas which are in what we call initiation phase, except for genomic medicine at the bottom there. Now, when the radiologists discovered of heard about how the pathologists are doing, they are also reconsidering now working in a more structured way. They want to structure their reports, and they also want to use SNOMED. So that would be a very good combination using for both pathology and radiology, because these two specialties are very important in cancer care for patients. The other project that is at its initiation phase is an action against obesity in children. So this is also a national project. There are many private as well as public sectors involved. And the aim is to combat obesity among young children. And this is being supported by, the project had financing support from a semi-government called Vinova. Then we have this cancer and care protocols. These are two what we call government assigned projects to us actually at the National Board of Health and Welfare. And in these two projects, we are to work with what we call standardized and structured way of documenting cancer care for cancer patients. And similarly, we are there will be also a similar focus for schizophrenia, stroke, heart failure, and sepsis for a start. So this is what we are working with. And the last thing is genomic medicine. As I said, that it's not in the pipeline yet, but there'll be discussions later on. Genomic medicine Sweden has the ambition to store data for all disease states, especially genomic data. And in that data lake, they intend to also to have all kinds of treatment protocols and also clinical data that related to those diseases. So primarily, genomic medicine Sweden would like to go into more precision medicine and build up what we call AI for decision making, for beslutsstöd. What is that in English?
Decision support.
Yes, thank you very much. Yes, so that is a field that we will be going in the future. Yes, so back to you, Daniel.
Yes, going back to the regions again, and the way they are organizing knowledge management. So as I mentioned, they're setting up a structure where they have a set of national program areas. So acute care, child and youth, cancer, etc., etc. So there will be a responsibility for national care protocols in these program areas, which would be kept collaboratively among the regions on a national level. There are some aspects of healthcare which do not lend itself to these program areas. So there are a number of national collaboration groups, which for structured health information is one particular one of these, and these collaboration groups, they work on a horizontal level across these program areas, and should apply the expertise from the program areas whenever a particular particular area is being worked on, when this structure is put into practice, then this would be the place to go to get to achieve national consensus and to get access to national experts. So for this purpose, as a National Release Center, we're collaborating with this national collaboration group for structured health information, and among the different, very different tasks that have been put on the collaboration group for structured health information, is working out a national guideline for how and when to use SNOMED CT. They're working on also things like an infrastructure or specifications for national terminology services as well, as examples of things which are related to our work. But what we see is that when this structure has been fully implemented, this will be a main way of getting access to expertise and doing engagement with the clinical community. Keng-Ling. Keng-Ling, are you there? Or is it me that is? Hello?
So Keng-Ling's on mute if you're talking, Keng-Ling.
So I'll some of the challenges, I'll talk to this instead. So we have, as you've seen, we have a decentralized mandate. The responsibility for healthcare is distributed, and we have limited means of like deciding on these matters. So instead we have to collaborate and try to be provide as much service as possible. But as I mentioned earlier, SNOMED in itself is not what we're trying to achieve. We're trying to achieve a better healthcare provision through the use of better informatics, and SNOMED is a component. So we have to work with the healthcare providers and those working with healthcare knowledge management in order to achieve this. And there we also need to find like the best way of doing clinical engagement. We're seeing a paradigm shift. So we've been SNOMED members for more than 10 years. In the early years, we saw SNOMED use mainly in national projects, and there were a like trial and error approach to implementing SNOMED. Now we're seeing more of a pull situation and less of a push situation when it comes to SNOMED CT. Knowledge about SNOMED CT is still scarce in these organizations, but the situation is of course much better And we're particularly thankful for the education that SNOMED International is providing. And we still have legacy issues with older healthcare system that we have to work around, like having length of codes and trivial things like that is still an issue in many projects. So with that, I think we would like to thank everyone for bearing with us for 40 minutes and see if there are any questions.
So thank you, Daniel, and thank you, Keng-Ling. So yeah, we have some time left. So do we have any questions? So I see chat's been very busy. So are there any particular points from the chat that people want to make?
This is Peter. I was wondering if there are any health information exchanges, either regional or national, in Sweden that use SNOMED.
Yes, and so I think the first SNOMED exchange was something like early, so 2012 something. So there is SNOMED. So we have so the national medication list that I was talking about before, that there was a law to be enacted, that has partly been implemented. So we have a national list for reasons for prescription. So it's basically SNOMED clinical findings, most of them at least, which are used to specify the reason for prescription, and that has been implemented in some region, and it is communicated nationally. We have SNOMED used for laboratory medicine, so we're not using LOINC, we're using NPU terminology, which is a competitor to LOINC, but we're using SNOMED for everything else. So this has implementation is ongoing, but there are lab messages being sent with SNOMED content for nominal scale results, for specimen types, specimen collection location. So a number of value sets in that laboratory medicine domain is SNOMED, and that is in actual use. With the national medication list being implemented so the plan was that it would start June this year, and then there would be an implementation period of 2 years, and then it would be mandatory, and that would include a lot of SNOMED. Where we still, I guess, trailing is use of SNOMED in clinical information systems where there is no national reporting requirement or national infrastructure. That has been partly due to legacy issues. So, but with Millennium being implemented, with the Cambio vendor has recently developed I don't know that much about this, but we've been in contact with health regions that use the Cambio software, and they have done a development of the system to allow use of SNOMED codes in a meaningful way, and so on. So we hope that there will be a shift in clinical, like broader clinical use of SNOMED in health information systems. I think there are some, I don't know if anyone, there are some people from the regions, and I saw a vendor Swedish vendor on the call, so I don't know if anyone wants to. Organisms, yes. So for microbiology, with this new laboratory medicine protocol, organisms are SNOMED coded.
Thanks.
And I probably missed something, but yeah, it's. Any other thoughts?
So any final questions?
Daniel, how is vaccination and immunization recorded in Sweden generally?
Oh, that was an extremely good question, and I'm not updated about it. There is a national vaccination database, and I probably should know in what ways they're using SNOMED, but I don't know off the top of my head. Anyone else on the call who knows, please chime in. I know that, so vaccinate, it's used in the European patient summary. It's SNOMED for vaccinations. So I'm sorry, I don't know, or maybe I do, but don't remember right now.
No, sure, yeah. Obviously, my underlying reason is that I think there are some interesting challenges coming up in recording vaccination for COVID-19 coming. I don't think many systems could show experimental vaccination in volunteers, but it's something we should be thinking about nationally. In the UK, I think as long as your GP has provided the vaccination, then it's recorded in SNOMED using SNOMED concepts in a procedure list in all of the GP systems that are used in the UK. But I think it's an interesting challenge, particularly now thinking about the health and happiness of the world population.
Yeah, I couldn't agree more.
And Sweden's obviously a special case.
Of course.
Yeah. So well, that's another discussion.
I'm not sure, Daniel, when it comes to using SNOMED for vaccination like COVID. I'm not sure just if they use it when they're reporting, but from what I've heard, in the registry's site, they are including COVID SNOMED city codes there. For analysis.
For the quality registers. Is that okay?
Yeah. For example, this in the register utilizing tool, that is the database for all registers. They have incorporated SNOMED city code for COVID-19, both the infection as well as for COVID-19 vaccination.
Yeah, I was sorry, I was Googling for trying to find out, yes. But yeah. So we'll have to. Okay, so we have some some hot information from the Cambio, the Swedish vendor, and Mikael Nyström. Some of you probably know. He's been working with SNOMED as long as I have.
Okay, well, looking at the time, I'm going to bring this webinar to a close as we're to time. If you can just stop sharing your screen a minute, Daniel. Okay, and I'll hang on a sec, and I'll just share mine a second. So one of the questions in the chat window was, will the meeting recording be available? So most of you, I think, will be familiar with this. So we use Confluence, and the clinical engagement team, of which I loosely head up, has my colleague Charles, who's on the call, and Peter, who's also on the call, and Jane, who was unavoidably detained this evening. But if you go on the clinical engagement site, you'll see there's a tab called Clinical Community. And under there, there is a conference call, meetings, and a whole series of webinars. And for each of them, if you click on them, I'll post the actual link to the Google file on that site, as well as the presentations. So you can get hold of the presentations and the recording afterwards. And with that, I'd like to firstly thank all the speakers this evening. Hopefully the attendees have enjoyed the session. Definitely keep in mind the clinical session that we're running in October as part of the Expo, the SNOMED Expo meeting. And I bid you farewell and hope you have a good evening or a good afternoon or a good morning, depending on where you are. So thank you and good night.
Thank you very much.
Thanks very much.
Thank you.
Thank you, Ian, and thank you, everybody.
Okay.
Yep.
Thank you.
All right.
Night.
Thanks, everyone.
Bye bye.
Bye.